Here on GameChangers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting CEimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count.
Hey CEimpact subscribers, and welcome to the GameChangers Clinical Update Podcast. I'm your host, Rachel Maynard, and today we're going to be talking about the role of atypical antipsychotics, also called second-generation antipsychotics, in managing depression. And this is coming up because an atypical antipsychotic, lumateperone, was recently approved as an add-on therapy along with antidepressants for the treatment of major depressive disorder in adults. And it joins other atypicals, including aripiprazole, brexpiprazole, and quetiapine extended release, as antipsychotics that are approved as adjunctive therapy for depression. But this recent approval made a bit of a splash in headlines, and it raises questions about when lumateperone should be considered as an add-on for depression, as well as when second-generation antipsychotics fit in more broadly for depression. So to help us dig into this topic, I'm very excited to introduce our guest today, Dr. Sarah Grady. So welcome, Sarah.
Morning, Rachel. Thank you.
We're so happy to have you. I know you've got a very busy schedule, so really appreciate you taking the time to chat with us today. And for our listeners who haven't heard your voice on the podcast in the past, I know you've been on before, could you share a little bit about your background, your current role, and why you're interested in this topic?
Yes, thanks again. My name is Sarah Grady. I'm a professor of pharmacy practice at Drake University College of Pharmacy and Health Sciences. I'm also a clinical pharmacist on the inpatient behavioral health unit at Broadlawns Medical Center. So I assist in the care of many patients that have depression, mild, moderate, severe, as well as difficult to treat depression. So very interested in this topic.
Excellent. Yes, it sounds like you'll have a lot of great practical experience to share with our listeners today. So let's just start out by talking about lumateperone, which is this recently approved drug as an adjunct to major depressive disorder. So if we could just have an overview of what lumateperone is and what it was previously approved for and how it works, that would be great, I think, to help level set us, get us on the same page.
Yeah, so lumateperone has been out since approximately 2019. It was originally FDA approved for schizophrenia. Since then, it's achieved FDA approval, or I should say acquired FDA approval for bipolar 1 and 2. And most recently in November, as you stated, it received the adjunctive agent for depression approval. How it differs a little bit from the other second generation antipsychotics with regards to its mechanism, there are a few ways in which it differs. The first way is that very strong 5-HT2A antagonist. Obviously, the other antipsychotics have that mechanism as well, but this is very, very strong, quite strong. It also has serotonin reuptake inhibition properties. So this may give it some antidepressant effects that differ a little bit from the other second-generation antipsychotics. Many second-generation antipsychotics also have antidepressant properties, but none really have a great deal of serotonin reuptake inhibition. So this is a difference in mechanism. How will this translate clinically? We obviously know it's got the FDA approval, but how will it work for the individual person? Sure. It's going to probably work for some people. It's not going to work for everybody, but we will see what happens. I feel like in the management of depression, we need every single tool and agent and technique available. So this just adds to our tools, and it might be appropriate for some people, but it may not be appropriate for everybody.
I think you've highlighted a really important point that will come up probably again multiple times in our discussion, but thank you for the summary and also for sort of tying in how the mechanism may potentially theoretically have benefit for depression to that serotonin. How did you describe it? Serotonin or serotonergic?
Yeah, the serotonin reuptake inhibition. Yep.
Right. So again, as we think about our SSRIs, similar sort of potential benefit there. Again, strictly through the mechanism of action, how that will play out clinically may yet be seen. But that actually transitions nicely into this new approval for lumateperone as an adjunct for depression. And so maybe you can talk a little bit about some of the clinical studies that were used to get that approval and what kinds of data we have so far.
Yeah, so the clinical trials again showed some some good results looking at the primary outcome measures, a reduction on the MADRS. The MADRS is the kind of one of the gold standards that we use for scoring depression, and it did show improvement compared to placebo. And the trial was set up in a similar fashion to some of the other second generation antipsychotics that currently have FDA approval. So again, some good measures that they looked at. They had rather strict inclusion and exclusion criteria, which is typical for a trial such as this one. So again, the trials look beneficial, but we will have to see how this works out clinically in practice.
Yeah. Okay. And I'm glad you reiterated that because, as you say, real world data can sometimes look different than these trials, which are often very short. I think these were no more than a few weeks of duration. So how that will play out longer term is always sort of yet to be seen. And you mentioned it was studied versus placebo, but just to be clear, versus placebo, but in patients already on antidepressants. Is that correct?
Correct. They
Okay.
were already on, because this is an adjunctive trial, so they
Right.
were already on antidepressant therapy. And as you mentioned, these are acute trials, so 4, 6, 8 weeks in duration, and also a couple hundred patients in each
Yeah.
treatment group. So I think
Yep.
it's important to keep that in mind because that's why we'll need to see how this plays out clinically.
Right. Absolutely. Okay. Great summary there. So we've got that foundation with lumateperone. Let's talk about second generation antipsychotics more broadly and their role as adjunctive therapy for depression, because not everyone with depression needs a second generation antipsychotic. So what really is the broader role outside of lumateperone specifically for these second generation antipsychotics in managing depression?
Absolutely. They are geared mainly toward individuals that have a partial response to a traditional antidepressant.
Okay.
And so I can define what a response is. A response is a 50% reduction in baseline symptoms.
Okay.
A partial response would be a 25 to 49.99% reduction in symptoms.
Okay.
Okay, so these are really geared towards people that have that partial response mainly. This is what they're geared towards. And again, the evidence is there that they can be helpful for that partial response. But I want to make it clear that there are also other options that can be helpful for a partial response. And clinical practice guidelines highlight these options available for partial response. Obviously, they include the second generation antipsychotics, but you can also consider psychotherapy if you're not already doing that. And there are other agents that have been studied for partial response. They may not be necessarily listed high ranking in treatment guidelines, but we can look at them. These include agents such as lithium, buspirone. We have thyroid hormone supplementation. So there are lots of ways that you can manage partial response according to treatment guidelines. Another thing you can do, first and foremost, is we want to, and we can do this as pharmacists, we want to see are they taking, whenever a patient tells me my antidepressant isn't working, I ask them kind of the obvious questions. You're trying to take it every day. Is your dose high enough?
Mm-hmm.
Has your duration been long enough? All those things matter. And especially if somebody thinks the antidepressant, the traditional antidepressant, might be helping them, we might want to look at increasing the dose. And, we want to stay within the FDA recommended range. But, for example, if they're taking sertraline 100 milligrams and they're seeing a partial response, they're feeling a little bit better, maybe we can see if they can tolerate a higher dose, and so maybe look at dose optimization, considering all our options for partial response. Obviously, that includes our, our second generation antipsychotics, but we have other medications that we can look at too.
You called
So
out so many important things. Yeah, go ahead. Sorry.
no, my apologies. The point is we have a lot of options. And yes, second generation antipsychotics, they have the FDA approval, and we want to consider them. But we have lots of other routes we can go if somebody doesn't feel comfortable starting one of them for whatever reason, so lots of options available, which is a good thing.
Yeah, absolutely. And like you alluded to with the approval of lumateperone, it is another tool in the toolbox. And I think that also resonates here, where we have lots of tools in the toolbox more broadly in terms of how patients can be managed, not necessarily going to a second generation antipsychotic or even this specific drug per se. So, but yeah, you brought up so many important points there. I just want to reiterate a few of them. The idea of partial response and evaluating that. And one thing that comes to mind is the idea of giving the traditional antidepressant, as you said, at the optimized dose for enough time. So what, as you said, that's a really important part for pharmacists to be looking for. So what is the dose? Is it optimized? And then how long, because it takes time to titrate too. And so how do you consider all of that? If a patient is starting out on an antidepressant, a traditional antidepressant, how do you ensure, what kind of time frame are you waiting for them to get to that optimized dose? And then how long should they expect it to take for the antidepressant to kick in at the optimized dose? What is that sort of time frame that you're looking for generally?
Yeah, it's a on average, it's lengthy.
Yeah.
And that is difficult for everybody. It's when folks have depression, not feeling well, wanted to feel better yesterday.
Right.
It can really take these medications, several weeks, really.
Yeah.
Most of our medical literature states that it can take, a full 6 to 8 weeks or longer to see full therapeutic benefit. And because again, we need to factor in titration,
right.
And so yes, like I said, really 6 to 8 weeks or longer to see a therapeutic benefit. That's an average. There will be some individual variation, like there always is, and that's another reason why it makes mental health management a bit challenging, from time to time. But again, pharmacists, we're perfectly positioned to kind of reiterate these concepts, along with adherence, taking the medication every single day. I think the other thing that kind of compounds traditional antidepressant treatment is that on average, different symptoms will start to improve at different times. So we always like to say that the physical symptoms of depression, sleep disturbances, appetite disturbances, low energy, those symptoms may start to improve before the emotional symptoms of depression. The emotional symptoms of depression are the sad mood, the loss of interest in activities one normally finds enjoyable, the suicidal ideation, so physical symptoms of depression may start to improve before emotional symptoms of depression. And, that's one of the reasons why we have, the black box warning, because particularly in younger people, this can happen to anybody, but energy may improve before the emotional symptoms. And so this can be problematic. So we have lots of factors, I guess, going on with traditional antidepressants. But yes, really, if you look at the the trials among the traditional antidepressants, those are 6-week trials, typically 8-week trials, and there's a reason for that.
Yeah, yeah. I think that's such an important point to drive home because, as you said, pharmacists educating about this, helping patients have realistic expectations when they're starting. So I think it's great you called out physical symptoms result or improving before emotional symptoms, but just the length of time this can take generally and supporting them through that titration and with adherence, as you said, even if you're not feeling full benefit, continue on to see if you're going to get that response. So you mentioned the antipsychotics as an adjunct for patients with partial remission or partial response, I should say. When would you think about switching to a different traditional antidepressant versus then adding the antipsychotic or another adjunct? But when do you think about switching versus adding?
Yeah, great question. I can think of a couple scenarios.
Okay.
Number one being, so I talked previously about response, 50% reduction from baseline symptoms, partial response, 25 to 49.99% reduction in symptoms. Non-response is considered less than 25% reduction in symptoms. So certainly when somebody has non-response to an agent, and again, we have to factor in, are they taking it every day as prescribed? Is the dose high enough? Is the duration long enough? So we have to factor in those three. Also, if they're having side effects that are bothersome to them.
Sure.
I think in a lot of cases, depends on the person, but some people understandably feel so terrible with the sad mood and the other symptoms of depression that they may be willing to tolerate maybe some dry mouth or maybe some of the stomach upset, some of the other antidepressant side effects that are commonly seen. But let's say they develop a side effect that it's just too bothersome to them and it makes them feel even worse than they already do, then that would be another scenario where we wouldn't want people to be on the drug.
Okay. And when thinking about antipsychotics specifically in the menu of other options that you have as an adjunct, and considering some of the pros and cons with antipsychotics broadly, how does that factor into your decision-making process with the patient?
Yeah, front of mind. I feel as though there is always, I don't want to say always, but there is usually a risk versus benefit discussion.
Yep.
So we know the benefit of some of these second generation antipsychotics that have FDA approval for this. The data is out there. So we know the benefits. What we need to discuss, especially as pharmacists, are the risks, and mainly the risks of long-term use of second generation antipsychotics. So we need to be talking with patients about the risk of what we call drug-induced movement disorders, formerly known as EPS. Okay, so risk of tardive dyskinesia, although the risk of TD is low. With the second generation antipsychotics, it's not zero. So whenever I am speaking to or with a patient about an antipsychotic, I don't care what it is. I don't care what the purpose is. Take aripiprazole, for example. I would say in my setting, its most common use is an adjunctive agent for depression. So we have many patients that are on aripiprazole for that purpose, and they're on low doses. And I'm always letting them know about the risk of tardive dyskinesia with long-term use. Low risk, very low risk, but not zero risk. And again, pharmacists in any setting can certainly talk to patients about that. Metabolic risks. So the agents, most of the agents, with the exception of quetiapine, most of these agents are going to have a lower risk of weight gain and hyperglycemia and dyslipidemia, but again, may not be zero. So I'm always encouraging patients that are taking an antipsychotic and they're going to be using it long term, we want to be monitoring that. And some of these agents, certainly not all of them, we can sometimes have some increased prolactin levels. Again, this is going to be less of a factor with the second generation antipsychotics that we have FDA approval for this purpose. But like I said, I really think that pharmacists in every single setting that, if we're taking care of folks that are taking antipsychotics for any purpose, we do want to let them know about and ongoing conversations about the risk of drug-induced movement disorders, metabolic side effects, and depending on the antipsychotic, the risk of hyperprolactinemia.
Absolutely. Those are definitely important safety considerations to be educating patients about, and also, again, thinking about those in the risk-benefit analysis when you're considering what options are available for patients who've had partial response. So considering all those, do atypical second-generation antipsychotics still provide where do they sort of rank in terms of the options where you might think about next steps for a patient with a partial response to a traditional antidepressant? How does it sort of stack up?
Yeah, great question again. This is where I like to look at our treatment guidelines. And in the last couple of years, the more recent treatment guidelines have definitely put second generation antipsychotics in the conversation for looking at them as an adjunctive agent. But I want to underscore they're not the only agents that have been moved up in the algorithm, if you will. Another option that has moved up in treatment guidelines is psychotherapy. So again, I want to underscore, yes, they are an option. They are a good option for some people, not everybody. I always I feel like in my practice settings, particularly I'll use aripiprazole as an example, just because we are at this time at my institution using it the most out of the other FDA approved agents, probably because it's had this indication the longest,
right?
And we're familiar with it. But we are really watching to see if it works or not. We are really watching to see if the patient is comfortable with it. Many of our patients are, but not all of them. In the case of aripiprazole, we see a lot of side effects of akathisia, feeling restless. And particularly when we have someone that has depression, they have loss of interest, suicidal thoughts, we don't want them feeling restless. So we are very intentional and deliberate in watching, is it working for the patient? And if it's not working, we transition them off of it. Again, that risk versus benefit.
Yeah, and shared clinical decision making, having those conversations upfront with the patient, helping them wade through the options, and then as the patient is starting and continuing tolerability, evaluating, reevaluating. So all part of that standard patient care process. I love that you called that out. I think what you have been highlighting in your practice is a great opportunity to sort of segue into the role of lumateperone, since that was our hook for this discussion and why we're sort of talking about this more broadly. Where do you think it's going to fit in compared to other second generation antipsychotics in this role as adjunctive therapy for depression? How does it sort of compare or stack up?
Sure. Yeah. And I'm still, it's a newer agent, right? So I'm like everyone else, I'm still learning about it, and I'm still thinking about how it fits in, or what differentiates it. More importantly, again, the first thing that comes to mind is it does seem to have a different mechanism than the others. And again, so that might play a role, I guess, in two regards. One could be, yes, for some people, it may really provide that additional antidepressant property, which is what we're looking for. But the other thing, Rachel, that I've been thinking about, because this is where trained as a pharmacist, I'm always thinking actually safety first,
Yeah.
because it has serotonin reuptake inhibition.
Yeah.
Will that put us at greater risk for serotonin syndrome with
Right.
some of our SSRIs and SNRIs? And I noticed that, that is mentioned in the medical literature a little bit. The clinical trials didn't pick that up. But again, they were short duration,
Right.
and hundreds of patients, versus thousands. So
Right.
I feel like pharmacists, especially, in fact, I had a physician call me a couple of weeks ago. They saw the new indication and they said, well, what do you think? I read the trials just like you did. Yes, it can be helpful. Stats look decent. Yes, we got to factor in the not a long duration, couple hundred patients versus a couple thousands. We got to factor all that in. And I said, yeah, on paper, it looks good and obviously has FDA approval. But what I don't know about is, will we have a risk of serotonin syndrome? I don't know. I don't know, but I put that, I just mentioned that to the physician. They're like, yeah, I got to monitor for that. And let's let the patient know about that.
Yeah.
So that's probably, a safety mechanism for we as pharmacists to think about. The other thing that we've been seeing, so we have been using, the newer agent for this indication. We have been using it at our practice, but not for this purpose. We've been using it for schizophrenia. We've been using it for bipolar. We are seeing, it varies per person, but we are seeing from a side effect profile some sedation. So we've been using it at bedtime. So this may factor into folks that they have the type of depression where they just can't sleep. They can't sleep well. Even maybe the traditional antidepressant has helped the insomnia a little bit, but they're still not sleeping well. So maybe lamotriptone would provide some additional sedation for them. So sedation, we're seeing some dry mouth, we're seeing some nausea again, and I think the nausea is probably from the serotonin reuptake inhibition. So, those are just some things to factor in. So to summarize, we'll see how it plays out, but just on paper, it looks like the mechanism may add something to what's already out there, from both an effectiveness standpoint as well as a safety standpoint. Again, I'm hoping for the effectiveness standpoint, and certainly that's what we've seen in the clinical trials. But we've talked about the potential limitations of our trials, and as pharmacists, we will be conducting further post-marketing surveillance.
Sure. Great summary. And that ties into a lot of the counseling points we'd want to be thinking about with patients starting this too. And I love how you brought together that serotonergic effect could be providing some benefit in this specific indication, but also could be introducing some risk in this indication because these patients are also going to be on traditional antidepressants, often which have serotonergic effects. And so, yeah, that's a very good consideration. And then when you think about serotonergic considerations and other meds that can then add to that burden and sort of tip a patient over potentially, is having that on your radar is really important, because I don't know that I would necessarily think of a second generation antipsychotic as having a serotonin, potentially contributing to that burden. So really important point to call out there. And the sedation also is an interesting consideration. As you said, if a patient's struggling with insomnia, this may have potential benefit there for some patients. As you said, it's so patient specific, right? And we really need to think about the individual patient and what's going to be beneficial or not for them. But
yeah,
really, yeah.
And Rachel, I bring that distinction up just because, again, we are most familiar at my setting with aripiprazole for this purpose.
Yeah, sure.
And aripiprazole, it varies per person, but aripiprazole, especially at the lower doses that we use for depression adjunct, it can activate people, it can energize people.
Right.
So We usually give it in the morning. Yes, there's
Mhm.
always a few people it makes tired, but that is a kind of a differentiating factor, I think. And
Mhm.
earlier in the podcast, we talked about, quetiapine. Obviously,
Mhm.
quetiapine can be
Mhm.
sedating, but I think it's good to have a mixture of
Right.
things that can maybe add to some energy or maybe help with sleep,
Mhm. Mhm.
symptom wise, because the sleep can be an issue, whether it's
Mhm.
insomnia or hypersomnia.
Mhm. Mhm. So, in terms of any other practical considerations or counseling points that you want people to know about with lumateperone, the other thing that's coming to my mind is cost, because aripiprazole, as you said, has been around for years, has had that indication for years, is generic. This is not going to be a generic. Any other considerations that our listeners should be aware of when thinking about this sort of new introduction into this indication?
I'm thinking, and yeah, thank you, of course, for mentioning the cost factor, because we have to factor that into the risk versus benefit.
Of course, yeah.
But yeah, again, the difference in mechanism, I think pharmacists want to highlight, which can be a positive thing, which we saw in the studies, but again, may contribute to that serotonin burden. So we want to probably think about that, and of course, the mentioning the long-term potential adverse effects with
Mhm.
antipsychotics
Right.
in general, the drug-induced movement disorders, especially tardive dyskinesia, metabolic risk, and risk of hyperprolactinemia with some of the agents.
Mhm. Mhm. Good counseling points to keep in mind with these second generation antipsychotics in general. Um, we talked about the sort of onset effect for traditional antidepressants. How long would you tell a patient to expect to see onset of effect for an adjunct antipsychotic in general?
Yes, excellent question. And we expect to start to see some improvement in, I guess, those residual symptoms of depression really by 2 weeks. We should
Okay.
start to see something.
Okay.
Not full
Sure.
benefit, but we should see improvement in something by 2 weeks. Depending on the agent, when used for this purpose, we might start to see some earlier results compared to traditional antidepressants. I would say certainly at 1 month out, we would
Mhm.
want to see improvement. And if we're not seeing improvement, then we're going to have conversations about, do we leave this on a little bit longer? If so, how much longer? Um, because again, risk versus benefit.
Mhm.
This is just my personal opinion, and I always share this with patients. It is my personal opinion, but if with the potential long-term side effects of antipsychotics, if
Mhm.
they are not helpful, we
Mhm.
don't want to be taking them, and we want to look at other options for
Mhm.
augmentation. And as
Mhm.
we stated throughout the podcast, we have other options
Mhm.
that can be
Mhm.
helpful. Optimizing the dose, switching the antidepressant, adding on therapy, adding on, and even we didn't speak about this, but even maybe adding on another antidepressant to a
Right.
traditional antidepressant. There's data for that. So, yes, and again, this is where pharmacists in any setting can be instrumental. Let's say there's someone coming to your pharmacy to picking up their second month of their second generation antipsychotic for their depression augmentation. Particularly if you know that patient well, okay, we expect to see some benefit by now. We expect to see something. Um,
Mhm.
Again, we want to verify adherence because maybe they're
Mhm.
showing up at your pharmacy 5 or 6 weeks after
Right.
they're starting it.
Right.
And if they're not taking it every day as prescribed, um, it it's not going to work. We're not going to get the best effectiveness from the medication.
Right. Well, I love how you're reiterating the point on adherence and the crucial role for pharmacists, because often we do have visibility into when that refill is coming up, and that is right about the time frame when we would be hoping to see response. So good, great time to check in, have that conversation around tolerability, but also efficacy and how the patient's doing overall, and then reevaluating, because as you said, this isn't our only option. We have lots of options. So I think that's a great point to tie that all together. And thank you for also speaking to how long we expect to see that benefit, because I think that's a consideration that we should be thinking about when we're seeing those patients at the check-in. So we're about out of time for today. So it is our Game Changers podcast, and we do want to wrap up with a game changer and what you want our listeners to walk away with today. So what would you say is the game changer, Sarah?
I'd say the biggest game changer is we have another tool in our toolbox in our fight against this condition that impacts many people all over the world. It may impact us. It may impact our family, our friends, our colleagues. So yes, like anything else, it's not a perfect option, but it's another option. And it's an option that can maybe help some of our patients. It's not going to help all our patients. It's not the right option for all our patients, but a game changer is we have another option in our toolbox.
Excellent summary. Another tool in the toolbox is a great takeaway, and also waiting and seeing how it pans out in the real world. We'll have to wait and see, and maybe check back in a couple of years.
Yes, we're going to cross our fingers.
That's right. That's right. Excellent. Well, thank you so much, Sarah. I really appreciate your time and your expertise on this topic.
Thank you, Rachel. You have a good day.
Thank you. So listeners, be sure to claim your CE credit for this episode of Game Changers by logging in at CEimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.